Many patients come in complaining of dry eyes to our office here at Visionary Ophthalmology, and I hand them usually this step-ladder approach sheet, which kind of goes through all the treatment options that are available to any patient in the world with dry eye symptoms. The first we usually do is try a more natural way of trying to help with dry eyes. And what we generally do is try to use the patient's own body to help improve the symptoms. So we start first with step one. The first step is lid hygiene, which involves warm compresses and baby shampoo scrubs. We essentially have patients put a hot towel with hot water on their eye for 10 minutes in the morning and night, and if possible, even during the day. It's kind of like brushing your teeth. You really have to do it every day. We then, after the hot compresses, which can be a hot towel, hot tea bags, hot water, wash the face with hot water or the hot towel. Once you've done that, in the morning and nighttime, we take a little drop of baby shampoo, put it on the hot towel and lather it up, or patients can take a few drops of baby shampoo and some hot water in a cup, take the hot towel, dip it, close the eyes, and clean the eyelashes. Wash off with warm water. That helps quite a bit in terms of helping the meibomian gland of the eyelash open up and work normally. In addition, sometimes we'll give patients something called erythromycin ointment or Tobradex ointment. As long as they have no allergies, what you do is you wash your hands, put a little bit on your fingertip, close your eyes, and put a little bit on your eyelashes before you go to bed. And in the morning, wash it off with hot water. If you wake up in the middle of the night, you're going to have blurry vision, so we tell patients to just be aware of that. This ointment basically removes the bacteria away from the eyelashes to help prevent the bacteria from getting into the glands and causing scarring. It also reminds patients to really rub off, wash off that ointment with hot water, so they'll use the heat to help their meibomian glands work better. In addition to step one, we really recommend a very good diet. That includes a diet high in omega-3s. You can either take it as wild salmon in terms of eating it, walnuts, fish oils, or you can take a pill. They have pills with omega-3s available over the counter. Additionally, I recommend to all my patients now to think about their diet in terms of what they're eating, trying to eat foods that decrease their inflammation risk in their body. There's a great book called Inflammation Nation that I highly recommend that goes through all the different options in terms of diet to help with that. And there's also over-the-counter spices that help, like turmeric and cinnamon, that helps improve the body's ability to deal with inflammation and decrease their level of inflammation. So I highly recommend that to all my patients. And then along with this, we do artificial tears. We use artificial tears and recommend it 4 times a day to patients if there's a preservative in the artificial tear. If there's no preservative, such as with Refresh and Oasis, which I think are the best, you can use it as often as you need it. If someone has itching along with the burning and dryness, we have them put the artificial tear in the refrigerator. The coldness of the refrigerator helps decrease the itching from the mast cells releasing the eosinophils. So that helps as well. And if somebody is having a lot of itching, which we think is due from allergy, which is kind of unrelated to dry eyes, but in a way is related due to just general inflammation around the eye, we'll recommend Pataday or Elasticaf once a day for that. If this is not enough, we'll then go to something more, a little stronger called doxycycline. Usually I'll give about 20 milligrams a day. I tell all patients to avoid the sun with doxycycline because it will give you a sunburn even if you have really good sunblock on. So during the summer months, I'll sometimes tell patients to come off the doxy if they're going to be out and then go back on in the fall and winter and spring. If that doesn't work, then we will then try the cyclosporin Restasis, and if there's no real concern for glaucoma, I'll give a low-dose steroid called Lotamax at the same time as I give the Restasis for the first 2 weeks, and then slowly decrease the Lotamax. The Restasis works very well for inflammation. The problem is that some people don't notice any effect until about 6 weeks after use. So I try to encourage patients to stick through the Restasis, continue it at least for 6 weeks, and then try to see if there's an improvement in symptoms. Restasis really does decrease inflammation of the conjunctiva. We know this. The problem is that sometimes it just doesn't make people feel better. So it can be very frustrating to patients when they don't feel an improvement, even though clinically and microscopically there is an improvement. When all of this is not helping or a patient needs something a little bit stronger, If the eyelids are nice and clean and there's no evidence of increased inflammatory cells under the microscope, we'll then place punctal plugs in the eyelid. Each eye has two puncta, one in the lower, one in the upper, so there's 4 of them. And sometimes we'll plug these the puncta with a plug to help the tears stay in the eye longer. If none of this is working, or if somebody wants faster relief and is tired of the warm compresses, we'll start with number 8, which is the new innovative treatment we have. And these are called the intense pulse light. There's LipiFlow and intraductal gland probing. The intense pulse light is a very intense light that heats up the lids, especially the meibomian glands, and allows the toothpaste-like secretions in those glands to come out. So that works very well for many patients. It takes about 15 minutes per session. Usually about 4 to 6 sessions are needed before an improvement is felt, and more than 70% of patients have been reported to show an improvement with this. So we're very excited about IPL. The other treatment that's available here in visionary ophthalmology is called LipiFlow, and LipiFlow works very well for many patients. About 79% of patients have shown an improvement of more than 10% with this treatment. LipiFlow usually is done about once every 10 months to have a sustained improvement. Intraductal gland probing is where we place a cannula in the meibomian gland. Sometimes we'll inject some steroid into the meibomian gland to break up any scar tissue. This works very well. It's a little bit more invasive, so sometimes we'll start with IPL first, then go to LipiFlow, and then if those are not working, then we'll go to the intraductal gland probing. With any of these treatments, there's no guarantee, but we do know that they really usually do no harm. The concern is that if you leave things as they are, the scarring will continue to develop in the meibomian glands, and once the gland gets scarred, that gland will never work again, and then that leads to a long-term dry eye. If none of these treatments work, we continue to go up the ladder, and then we start talking about the patient purchasing a moisture chamber pair of glasses. That's something that the patient will sometimes sleep with or use during the day. It essentially allows the moisture to lubricate the cornea during the day and at nighttime. And if this doesn't work, we'll go on to autologous serum, which is where we use the patient's own blood to create a special super tear that's full of all kinds of immunoglobulins and proteins, as well as very good lipids. If this doesn't work, we'll go on to Procera contact lens, and usually we'll use that if there's severe dry eye, there's neovascularization or new blood vessels along the cornea. And so we try not to use, obviously, very invasive treatments unless necessary. But sometimes dry eye can get so severe that it will lead to problems in the cornea, and that's where we go on to these other options. That would then include things like amniotic membrane, to place that and help decrease the scarring onto the cornea. Sometimes we'll need then to do a lid tarsorrhaphy and something called a conjunctival chalasis surgery. And if all of this doesn't work, then we usually will send them to a center that's starting to do research on lacrimal gland stimulation. But our goal at the Integrated Dry Eye Center here is to start here, beginning at the beginning, to avoid any scar tissue from forming.